Hello from Athens, Greece. We share with you a do-it-yourself orthodontic case, which unfortunately had detrimental effects on the teeth and the periodontal tissues. Let's see how we diagnosed and how we treated the case. A 9-year-old boy visited the Department of Orthodontics at the University of Athens, complaining of pain and swelling around the maxillary central incisors. The clinical examination showed that the incisors were extruded, exhibiting grade 2 mobility. The parents mentioned that they had used an elastic gap band to close the gap between the central incisors, following friends' advice. They said that the rubber band was visible for 2 days and then they couldn't see it anymore, so they believed it had most likely broken, but since the gap was successfully eliminated, everybody was happy with this do-it-yourself treatment. We stabilized the upper anteriors with a passive 018 Australian arch wire, and the patient was referred to the periodontist for further evaluation. The periodontal examination of the maxillary centrals revealed pocket depth measurements of 10 mm. Vertical bone loss was shown radiographically, and the teeth were estimated to have lost more than 75% of their bone support. No foreign body could be seen on the radiographs. The periodontal diagnosis was acute severe periodontitis of unknown reason. The rest of the dentition had no periodontal problems. The patient was seen every week and the mobility of the incisors continued to worsen. 3 weeks after the initial visit, it was decided to intervene surgically. Under local anesthesia, the periodontist performed an open flap debridement with deep scaling of the roots. An elastic band around the apices of the 2 central incisors was found and removed. Emdogain was applied along the root surfaces. The patient was in the intertransitional phase of the mixed dentition with a class 2 molar relationship subdivision right and also with increased overbite due to the extruded upper centrals. The periodontitis of the maxillary centrals continued to worsen, therefore extraction of these 2 teeth was inevitable.
2 treatment options were presented and both options included the extraction of the 2 maxillary central incisors. The first option aimed at prosthetic replacement and alternatively the second option involved lateral incisor substitution for the maxillary central incisors followed by aesthetic composites, build-ups or prosthetic restoration. An interdisciplinary approach would also be implemented. The patient's party decided to move forward with the second option.
It was decided to proceed with a slow, forced eruption of the central incisors to maintain the integrity and height of the supporting alveolar bone. After the central incisors were extracted, the lateral incisors received composite restorations and the biomechanics aimed at the mesialization of the maxillary posterior segments, which was achieved mainly with the use of class 3 elastics. Both arches were leveled and aligned, and a functional occlusion with class 2 molar and class 1 canine relationships with canine substitution by the first premolars was achieved. The final overjet and overbite were ideal, and the final panaural showed good root parallelism. The alveolar bone height in the anterior area was increased by the treatment. The treatment duration was 3 years and 9 months. The 5-year post-treatment records showed stability of the results achieved. The alveolar bone height in the anterior area was maintained, and the outcome satisfied both aesthetic and functional demands. Let's connect now with our co-author in St. Louis, Missouri, for conclusions and useful advice.
Patients and parents should know that the use of an elastic gap band to close the space between 2 teeth may result in severe periodontal destruction and eventual tooth loss. Prior to any tooth movement, patients are urged to see an orthodontist to find out their best plan.